Good evening and welcome to this International NASH Day that we are having tomorrow. This is on the eve of this day. We thought from the AIG we'll have a program on various aspects of this disorder. On behalf of the faculty of Asian Institute of Gastroenterology and AIG Hospitals, I'd like to welcome all of you to this program. I am Nageshwar Reddy. I work at the AIG, and the program moderator and the program coordinator would be Dr. P.N. Rao, head of department of hepatology at the AIG Hospitals. NASH is a very complex disease. The complexities of not only the etiology but the genetic background behind this, the various treatment modalities which have often not been successful, and the evolution in the whole thinking in the pathogenesis of disease makes it a very interesting disease. And over the last few years we had several thoughts on what is happening. At the AIG, our hepatology department has been very active in terms of looking at the basic science aspects in evolving the genetic cause of the disease, and also look at the various other mechanisms which are responsible for this. And also we are trying to look at the treatment modalities in terms of endoscopic techniques and so on. All of these would be discussed over the next 1 hour to give you an overall idea of what is happening in this field. And I'd like to welcome Dr. P.N. Rao, who heads the Department of Hepatology at AIG, to start the proceedings.
Thank you, Dr. Reddy, for giving in a nutshell an overall view of what we are going to discuss today. And as you all know, that we perform some international days of many things. We know every day, almost every day there is a international day is there. The reason to do this international holiday, recognize these, is to see the importance, especially in the matters of the public health importance also, and the scientific material also. In that one, we rededicate ourselves on that day, raise the importance level, raise the awareness level, and perform some conferences, debates, and public health important displays and things like that, and rededicate ourselves what we have to do for the next year till the next international NASH Day comes. I mean, we have here experts here. We got three experts, 3 hepatologists, Dr. Rajesh Gupta, Dr. Mithun Sharma, and Dr. Anand Kulkarni. And 2 basic scientists are there, Dr. Ravikant, who is in the Department of Genetics, and Dr. 2 bariatric people, in the sense that 1 physician and 1 surgeon, Dr. Rakesh and Dr. Abhishek, and Dr. Roop Jyoti, who has done excellent work in the field of pancreas, and then he is a basic scientist also in addition. And these are the people who are going to tell us about clarify some of the questions which we have. And when you look at here, actually, this is the Global Liver Institute is the one which has really was interested in, and then it has started this international NASH holiday. On the right side, you can see that what is the logo of the international holiday. There are about 80 partners in this one, and then 26 countries are there, of which India is of course one. And this is a very recent one. In fact, it has started only in 2018, and 2019, 2020, this is the 4th international holiday that we are celebrating here. In short, it is called an IND, International NASH Holiday, NASH Day. And in this, I can see here left side, this has been endorsed by the 2 main organizations, that is the ASLD, this American Liver Society, and the European Society, and various international non-governmental organizations, and then INASL is one of them. In fact, tomorrow, this on the eve we are doing it here. Tomorrow is the international holiday, International NASH Day. And on the right side, you can see that the national patients organizations and the foundations. In fact, anybody can join this international this community. As you can see here that this is in part diabetes, and then obesity, and then NASH. This Venn diagram is there, and you can see the very close relationship between these 3. And in fact, diabetes and then obesity, in fact, sometimes have been named as a diabesity. And there are several factors are there, including the gene. These are the things which we are going to discuss today. And as you know, obesity is now a global epidemic, and we are going to discuss about something on obesity, how to do the exercises and then other things. And also diabetes, as you know, that it has also been declared as an undiagnosed epidemic, and diabesity is a term, and the so close relationship is there. And on the top you can see that the diabetes and then fatty liver disease is a bidirectional disease. Why we should discuss about diabetes and then obesity is that this wonderful cartoon you can see here, on the left hand side you can see a person is a diabetic but he is not an obese person, you take it as standard. Person is a diabetic, not a diabetic, but he is an obese person, he stands an odds ratio of 1.13 for a malignancy, any malignancy for that matter. And for a person for diabetes yes, and obesity no, it raises to 4.38. And for anybody who has a diabetes and then obesity, both of them, the risk of ratio is about nearly 5 times this one. And the diabetes is associated with all types of cancers, including the liver, of course, is the one which is, I can see here, 2.5 times, and all the other cancers are also possible. So with this, we're going to start with Dr. Mithun Sharma now. And Dr. Mithun, can you just tell us, the NASH, what is that NASH acronym stands for, and then a little bit more details about the NASH, how common it is.
So thank you for the invitation on the eve of World NASH Day. So thank you. So NASH and fatty liver are two terms which many people use in synonym, and it's very common to our clinic. People nowadays come with a diagnosis of fatty liver. Majority of the time the diagnosis is made based on an ultrasound, which is the image on the right hand side of the screen, and to diagnose what is called NASH we actually need a liver biopsy. NASH is a diagnosis based on histology. When I talk about non-alcoholic fatty liver disease, it means that presence of fat in a liver in a who do not drink significant amount of alcohol. In context, it is very difficult to quantify the amount of alcohol in a real life clinical scenario, but non-alcoholic fatty liver disease can be classified as either non-alcoholic fatty liver, which means presence of fat in the liver. So a normal person has less than 5% of fat. If the amount of fat exceeds 5%, it is called fatty liver. But it has to be very clear here that mere presence of fat in the liver is not considered as the disease. When the fat in the liver leads to some worsening of liver function and inflammation of the liver, which is called steatohepatitis or non-alcoholic steatohepatitis, then it is a disease. NASH can progress to fibrosis and ultimately cirrhosis, and some patients of fatty liver can go into liver cancers without going through the stage of cirrhosis. The progression from non-alcoholic fatty liver to non-alcoholic steatohepatitis is something of a mystery. There are many things we know, that diabetes, obesity, diet are all related to fatty liver, but why some people progress to NASH and why some people do not progress to NASH? There may be a role of gut microbiota, cytokines, genetic predisposition, which is still not yet found. How common is NAFLD? NAFLD is very common, more in Western countries. The Western NAFLDs are basically typically obese people. The prevalence varies between 17 to 46%. And Indian studies are very sporadic. There is no universal database of NAFLD. It varies between 9 to 32%. Also, what is more interesting is something what is called as a lean NASH, which means that people who were thin can still have fatty liver. So there should not be a concept that only people who are plumpy and fat will have fatty liver. And what we have published from our institute, that people who were lean and have fatty liver, their metabolic profile is significantly different from those people who have fatty liver and are obese. The final question, that should I be bothered about fatty liver? The answer is yes. We should not be scared, because only a small percentage of patients who have steatosis progress to steatohepatitis, but 5 to 10% of patients who have NASH will progress to fibrosis and cirrhosis, and around 5 to 7% of NASH patients can have liver cancer without going through the stage of cirrhosis, and these are the patients who might end up in transplantation.
Mithun, you confuse me. Sometimes you say NAFLD, sometimes you say NAFL, sometimes you say NASH.
So NAFL and NAFLD are synonymous. Non-alcoholic fatty liver disease is a broader spectrum which includes non-alcoholic fatty liver, which means that it is only presence of fat without inflammation. When I use the term NASH, it means that there is fat in the liver plus there is inflammation inside the liver, which can actually be diagnosed only by doing a liver biopsy. The AST or the ALT values which we see in clinical practice may be normal, but yet the patient may be having significant inflammation inside the liver.
Okay, you said that histology is a must for diagnosis of, but everybody cannot undergo histology. But there are other ways of diagnosing the NASH also, I think, which we are going to
discuss.
go through.
So there are some non-invasive tests which have been done. There are some biomarkers and some scores which can be done to see whether there is prevalence of steatohepatitis. We have fibroscan, but that again doesn't tell out about inflammation. It tells us more about the amount of fat in the liver and the fibrosis. But yes, there are ways where we, by avoiding a biopsy also, we can identify possible NASH. But whenever the word hepatitis is there, ultimate the gold standard still remains as a biopsy.
Okay, thank you. We will come back again to you. Now we'll just, Dr. Anand, is NASH is only the cause of a fatty liver, or do you have some other causes also?
The central part of all these diseases is insulin resistance and obesity. Obesity, sedentary life, type 2 diabetes, any diabetics, most often it is recommended for all diabetics to undergo scanning for to rule out fatty liver. Presence of dyslipidemia, hypertension, drugs, commonly used drugs which are estrogen or tamoxifen, amiodarone, corticosteroids which are commonly used day in and day out, they can also lead to fatty liver. There are certain other dietary abnormalities which can lead to a fatty liver as well, like carbohydrate excess, protein deficiency, rapid weight loss, B12 deficiency, as well as choline deficiency. Then there are metabolic diseases which can also lead to fatty liver, such as hypo-beta-lipoproteinemia, A-beta-lipoproteinemia, Wilson's disease. Most Wilson's disease also can just present as fatty liver in the initial stage, and there are some syndromes which can also lead to fatty liver. Commonly, chronic hepatitis C is known to be associated with fatty liver, and retroviral infection can also lead to fatty liver. Then the history of fatty liver actually begins with in 1836 when Thomas Edison from England first described what is actually fatty liver. And there have been multiple sporadic reports about this fatty liver until 1980 when it was termed as alcoholic patients. Jürgen Ludwig, who described a series of 20 CLD patients with histological characteristics of alcoholic fatty liver, but without history of any alcohol misuse, that he termed it as non-alcoholic fatty liver disease. Then recently this term was again, it was recommended to change to MAFLD, that is metabolic associated fatty liver dysfunction, and it was published recently in the Journal of Gastroenterology.
Right. That means that NAFLD, people are now thinking that whether we should change it to MAFLD. That is a metabolic, the importance given to the metabolic syndrome. And initial stages somehow we could not see. What are the drugs, really, which are what drugs we should remember when there is a fatty liver?
Amiodarone, which is very commonly used for cardiac diseases. Tamoxifen, steroids are very common. Estrogen, which can also lead to the deposition of fat in the liver, and some extent of valproate. Valproate also can cause fatty liver.
So, in order to say that this is a non-alcoholic fatty liver disease, of course, alcohol so one should not be taking a significant amount of alcohol. We should rule out the drug causes, all the drugs which have been taken, and all the hepatitis, viral causes. So then when you said that a metabolic associated fatty liver disease, we should be knowing what is meant by metabolic MAF, metabolic syndrome. Here, Dr. Rajesh Gupta will tell us about what is really this metabolic syndrome and what is its importance, what is the relation to the fatty liver. Over to you, Rajesh.
Yeah. Thank you, sir. So, my brief is to talk about metabolic syndrome and what its relation with the fatty liver. So, metabolic syndrome is a broad group of disorders which comprises mainly obesity, high blood pressure, triglyceridemia, low cholesterol, HDL cholesterol, and diabetes, that is high blood sugar. So, if somebody who has more than 3 or more of these disorders, we classify it as metabolic syndrome. It's a group of disorders. Basically, it's one should have multiple disorder, and the significance of this disease is it's a part of multiple, it's a constellation of multiple disorders, and it can have main presentation of one disorder or it could be a continuum of disorders. So, what happens is, once somebody who has diabetes, or as in today, or hypertriglyceridemia or low HDL cholesterol, they may ultimately tend to over a period of time develop other disorders also, or say for example, if somebody has obesity and diabetes and hypertriglyceridemia, obviously it's at, but these patients, they can have concomitant deposition of fat, what we call fatty liver, and this is what the reason we call it is it's a conundrum, basically continuum of obesity to diabetes. So, anything can fit in, and in fact it is considered as a hepatic manifestation of metabolic syndrome. And the relevance of this knowing this fact is because it has been very well shown in multiple studies, and there is plenty of data to say that those who have fatty liver disease, they have high prevalence of both fatal or non-fatal cardiovascular events as compared to those who do not have fatty liver disease. So, this is the importance to knowing the metabolic syndrome and the components of metabolic syndrome what the patient is suffering from. I am not going to go into the details of the study, but this is a recently published data from one of the studies. So, why we should know? That is another question. What is the relevance? The relevance is the management point of view. NAFLD, as Dr. Mithun has already elucidated, that it's a broad spectrum starting from fatty liver to cirrhosis. So, it's a broad term. Fatty liver is a broad term. So, if somebody is having inflammation along with the fat, that is NASH, and they can have again fibrosis also without, and the grade of fibrosis may vary. So, that has clinical relevance in the sense, and knowing these facts, it is very, very relevant. And along with that, if somebody who is having cardiometabolic risk factors, that makes us much, it becomes more relevant or pertinent to assess what cardiometabolic risk factors are there along with the fatty liver. And it has a bearing on the management also, management strategy. If somebody has a fatty liver and simple obesity, so then our main focus should be, as for example, should be on the management of weight management, and that will have, obviously the main strategy would be managing the weight by diet, exercise, and the target should be more than 10% weight reduction. If somebody has a diabetes along with the fatty liver, then you have to manage diabetes mainly. And there are certain drugs which we have, and now we have plenty of drugs available, and now we have data also. And third thing is dyslipidemia. If somebody is having that predominant component of dyslipidemia and diabetes, you have to manage dyslipidemia as well. And if somebody is hypertension, of course we have to manage hypertension also along with the management of NAFLD. So, as already it has been said, NAFLD should be replaced by some better term, and that is probably it's a misnomer, and now there is a consensus. It should be labeled as metabolic associated fatty liver disease.
Thank you. I think the term metabolic MAFLD is still be recognized by the major scientific liver bodies, but you raise very important things. For metabolic syndrome is one of the important component for which you don't require lot many tests. You require very simple things. What you require is a tape to see what is the abdominal circumference.
Very rightly said.
And also one has to remember that as you know that the waist circumference will be different in Asians and then Westerners. So any Asian who is having, male who is having more than 90 centimeters or female more than 80 centimeters is considered to have a abnormal waist circumference, and they are more prone for metabolic syndrome. Other than that, you have to require only two things. One is diabetes, hypertension, and in lipids you are going to know about the HDL.
Yes.
So it is so simple for us to diagnose a metabolic syndrome, as
very
rightly said. And thank you very much for emphasizing that the close relationship between the metabolic syndrome, diabetes, and then obesity, and also emphasizing a very clear fact that you should tackle in anybody who is coming with a fatty liver, one should give lot of importance to management of obesity and management of diabetes, which we are going to discuss, how to do that in a very in subsequent things. Meanwhile, we'll see, what are the other things, other things which are important in the NASH, non-alcoholic steatohepatitis. Dr. Ravikant, you've been a genetic specialist, and we always feel that, for many of these diseases, there is a genetic background over which the environmental factors will, in addition, play. Do you think that this is a basically genetic disease? Can you just elaborate on the fact, the relationship between the genetics, human genetics, and the NAFLD? Over to you.
Sure, thank you. Good evening, all. We geneticists believe that most of the human phenotypes have a underlying genotype. Is it the case with non-alcoholic fatty liver disease and NASH? What is the proof? The predominant proof is in the indication that this phenotype has a familial aggregation. That's the predominant thing that says probably it is genetic. Subsequent studies on twins, genome-wide association studies, exome-wide association studies, candidate gene studies, and their functional, experimental, and animal studies have now proved that yes, there is a genetic component to the phenotype. Now, if you look at the heritability, it is anywhere between 22 to 34%, 22 to 34% in the general population, as well as high as 50% in twin studies. Now, apart from that, there is as high as 74% of shared environmental effects, which is very important. This suggests that yes, the genetics and environmental interactions are very important in causing the NASH phenotype. Now, if you look at the summary of genes that have been identified till date, they can be placed under various gene ontologies, including insulin sensitivity, resistance, high triglyceride levels, oxidative stress, etc. And all the variants that have been identified are across the entire human genome. Now, these are at the basic sciences level. Now, if we were to translate this to the clinical setting, it is better that we use something called as a polygenic risk score, that is put together all the variants that confer susceptibility to the phenotype and use them as a polygenic risk score. Now, there is an excellent study that has done this. They have taken around 5 genes, the variants which are known to confer susceptibility to NASH and the entire spectrum of non-alcoholic fatty liver disease, including the HCC, and they have genotyped these variants in a cohort. Now, they have grouped them into low PRS and the high PRS, that is the risk. In case of high PRS, the polygenic risk score is as high as 3.5 fold for the entire spectrum of NAFLD as well as with HCC. Now, if you look at the correlation, there is an excellent correlation for the major 2 variants, that is the TM6SF2 and the PNPLA3 variants, including a protective effect for HSD17B, the more recently identified variant, where there is a splice site variant in this that confers protection to NAFLD as well as the all the pathologies of the NAFLD. Now, if you look at the correlation, PNPLA3 as well as TM6SF2 are excellent correlation between severe fibrosis and these variants, as well as HCC, including fibrosis or without fibrosis. There is an excellent correlation for PNPLA3 and TM6SF2 variants. Now, if you look at the impact of the score on the full spectrum of fatty liver disease, there is again a higher risk for the entire spectrum, including fatty liver disease, fibrosis, and the HCC. Now, the hepatologists at AIG as well as the basic research scientists have been working to understand the genetic basis, and over the years we have published papers where we identified that the PNPLA3 variant, apart from a variant in PZP gene, confers higher susceptibility to non-alcoholic fatty liver disease and its intermediary traits including BMI, triglycerides as well as the ALT AST levels, and subsequent to that study we identified that even the TM6SF2 variant confers higher susceptibility to fatty liver disease. As discussed by the previous speaker, lean NASH, which is predominantly seen in the Asian ethnicities, we have identified a variant in a gene called PMT that confers higher susceptibility specifically to the lean NASH. Now, if you look at the take home points, key points, as sir has asked, yes, NAFLD spectrum has underlying genetic component, but the inheritance is complex with environmental factors also playing a predominant role. PNPLA3 confers twofold higher risk of fatty infiltration and is also associated with higher waist circumference and ALT AST levels. TM6SF2 again confers threefold higher risk of fatty infiltration. Almost 55% of the individuals that we tested until now have a variant in PNPLA3. Likewise, 32% have a variant in TM6SF2. As discussed, PEMT variant confers higher susceptibility to the risk of lean NAFLD based on the data that we generated and the data that is published across the different ethnicities. We reiterate that it should be part of the diagnostic algorithm to identify at-risk individuals so that appropriate interventions can be done early to see that they don't progress to the higher pathologies including HCC.
So that means genes are very important, but environmental factors are also equally important.
Yes, sir.
And do we advise routinely to people to do the genetic test for this?
Yes, sir, we advise, because once we identify a variant in the patient, it's always better to see that they do the exercise and all the other things so that the fatty infiltration doesn't progress beyond cirrhosis.
That means if there is an indication that there is a proneness to develop this kind of a thing, then they will take care of the diabetes, obesity, and then hypertension.
Yes.
And also perhaps this partly explains some people who are very obese, but they have a fatty liver, but it never progresses in them, to NASH and then other things.
Yes.
Maybe some of these things may be.
Interestingly, one variant in HSD17B13 gene confers protection to,
right.
but our own study says that in the Indian ethnicity it doesn't confer protection. So probably there are other variants which confer protection.
Yes. So there are some protective genes are also there.
Yes.
There are some genes which will
Confer
aid in both increase susceptibility to fat accumulation and also increased more progression of the liver disease. Some of the genes are responsible.
Yes.
So thank you very much. See, look here. There are some Trans-Siberian birds are there which travel thousands of miles from somewhere in Russia to Bharatpur sanctuary in the Rajasthan. There they have got a fatty liver. There they use the fatty liver energy from this fatty liver. But we say that the fatty liver in humans, it causes bad things, right? How does really, Dr. Rakesh, please tell us, how does really the fat accumulation progresses to cirrhosis of liver? Or what is exactly the pathogenesis here? Over to you.
So now that the previous speakers have told about how fat gets accumulated into and what is metabolic NAFLD, MAFLD. So now what exactly happens when fat gets accumulated in the liver? So that's very important. It's even the lean person can have, as it was pointed out earlier, and even obese person can have. So this is what this slide depicts actually what Mithun and other people have told. So how fat gets accumulated in the liver. So initially till probably 3-4 years before, the usual theory or pathogenesis behind this is the two-hit hypothesis, which includes the first hit as insulin resistance and deposition of lipids in the hepatic parenchyma. Second hit is oxidative stress in adipokines, adipokine disbalance or dysfunction leading to cirrhosis. Now the pathogenesis has taken the next level, that is a multi-hit hypothesis. A little complex side to look on, but I will try to explain. It's very simple. So as previously pointed out by the various speakers about the genetic involvement, the diet involvement, and the obesity. So if you see on the left-hand corner, I hope you can follow my arrow. So you have the genetic and epigenetic factors, which was explained by Dr. Ravikant. Then you have the dietary factors and the obesity. So this is one part or one hypothesis with which that leads to increase in the serum cholesterol and increase in the free fatty acids in the blood circulation. The second is the adipose tissue. So even a lean person can have visceral fat and adipose tissue, even an obese person can have. So when the adipose tissue increases, or there is a lot of adipose tissue in the body, there will be adipocyte dysfunction. And because of that, these adipokines will release the pro-inflammatory cytokines, which we quite often now come across during this COVID period, that is TNF alpha, IL-6 and IL interleukin 1 beta. So these enter the liver. So this is one path. The third or the fourth path is the gut microbiome, and which is very well established, and that's the reason why when you go to the management now, they say fecal microbial transplantation is also the choice for NAFLD. So what happens is gut microbiome is there is something called a leaky gut syndrome, which is in the loose terms we use. There will be increased lipopolysaccharides and increased gut permeability, leading to again increase in the production of these pro-inflammatory cytokines. So with all these things in a conglomeration, what happens within the liver is one end you have the dietary factors and obesity and the epigenetic factors leading to high cholesterol, high free fatty acids, and those free fatty acids get accumulated in the liver, and which leads to increased triglyceride production and more fat accumulation. On the other end, when the adipocytokines release the pro-inflammatory cytokines, those get into the liver and then they stay there. And the very other important is the insulin resistance, which was again touched upon by Dr. Rajesh Gupta. So insulin resistance leads to increased de novo lipogenesis. So you have adipocytokines, you have the external factors, you have the gut microbiome pathology and the insulin resistance. So all these together lead to lipotoxicity, which again leads to two main pathophysiological functions, that is mitochondrial dysfunction and endoplasmic reticulum stress. So mitochondrial dysfunction, as we all know, like any other inflammatory condition, leads to oxidative stress, increased reactive oxygen species, leading to inflammation, apoptosis and fibrosis, thereby leading to cirrhosis. And the ER stress leads to unfolding of the protein ribosome, which again leads to the same process of inflammation, apoptosis and fibrosis. So in toto, the multi-hit hypothesis is one is external factors, one is internal adipocytokine dysfunction, then the third is insulin resistance, and fourth gut microbiome. So these all lead to the evolution of NAFLD leading to cirrhosis or NASH leading to cirrhosis. So that's the reason why when you think of management of NAFLD or when it is pathophysiology NAFLD, you have to hit at multi levels and then try to see which is the one which is precipitating it and then try to address that problem. So I think that is what the pathogenesis is. Once you have this in mind, then the next part of understanding about NAFLD and NASH is pretty much easy.
Thank you very much. Thank you. Dr. Rakesh has told us how exactly the fat in the liver causes the inflammation and then progresses on to the fibrosis and then ultimately to the cirrhosis. You noticed, he has mentioned about IL-6 and then TNF alpha, because now the entire population in the world have been sensitized to this word IL-6, because they started doing in COVID disease only, and they think that IL-6
is a household name now,
and is a household name nowadays, and also it is raised in many conditions, in any condition, infective, non-infective conditions, wherever there is an inflammation, it increases.
Yep.
That is an important point to notice, because IL-6 raise, D-dimer raise is equal to COVID disease. Please, and one has to note that one. In between, after the inflammation, there is what is called a fibrosis. That means the liver becomes tough. How does the liver differ? But there are some cells called stellate cells. Stellate means star. We always tell them stellar performance. Stellate is a 17th century word which means that there is a star-like situation. There are some stellate cells are there both in the pancreas and also in the liver. Here we have got Dr. Roop Jyoti Talukdar, who has been extensively worked on the stellate cells of the pancreas, and he would also tell us now what exactly the stellate cells are there, what is their role in fibrosis in non-alcoholic steatohepatitis. Over to you, Rakesh.
Thank you,
Roop.
sir.
Roop.
Yeah, that's fine. So let's take a quick detour from the previous clinical things to a little bit of cell biology. This is a familiar slide which shows the progression of normal liver to NAFLD to NASH to cirrhosis. And if you see these histology, I will not go through in details. It shows different grades of fibrosis from lobular inflammation to cirrhosis. So why does this fibrosis occur? So there is a little cell called the hepatic stellate cell that Dr. P.N. Rao has already alluded to, and that was first identified by this gentleman called von Kupffer. We all know the name Kupffer cell, which is a famous cell inside the liver which acts as a macrophage. This was identified in 1876, and he called it Starzelen, which means star shaped, because these cells are shaped like a star. Several years later, actually, Ito, another scientist, observed these cells containing vitamin A droplets, and finally now both these cells described by Ito and von Kupffer were the same cell, which is now called the stellate cells. So it constitutes around 10% of all the liver cells within the liver. So what does it do actually in this normal physiological state? The hepatic stellate cells remain in a quiescent state between the hepatocytes and the sinusoidal endothelial cells. This is called the space of Deci. And when there is activation, for example, let's take the example of hepatitis A or hepatitis E, there will be transient activation of these stellate cells, and once the inflammation or infection is gone, the activated cell goes back to a quiescent state, either by apoptosis or it reverts back to the quiescent state. But if there is persistent inflammation, for example in NASH or in hepatitis B or in chronic hepatitis C, it goes into a state of proliferation, and the star-shaped cells now take the form of fibroblast or spindle-shaped cell, and it starts laying down fibrous tissue on the liver parenchyma, and that is the initiation of fibrosis. Now, what leads to activation of these hepatic stellate cells? There are a host of factors. In the context of NASH or NAFLD, as Rakesh and Mithun had very nicely described the pathophysiology. So there will be lots of oxidative stress inside the hepatocytes. So that is the first trigger that would activate the stellate cells, and that leads to lots of inflammation and infiltration of inflammatory cells, which further activates the hepatic stellate cells. And this is how the quiescent hepatic stellate cell looks like. Because of this excessive amount of vitamin A droplets, this is how it looks like in the electron microscopy. And when it gets activated, it loses all its vitamin A droplets, and it becomes a fibroblast-like phenotype. So what happens actually when there is activation of these cells? So again, if you see here, compare this picture with this one. So when these cells are getting activated, they change the phenotype, and here there is laying down of fibrous tissue or fibrosis, and which leads to contraction of the sinusoids, and that is the initiation of sinusoidal hypertension and the first step of portal hypertension in advanced NAFLD related fibrosis. And once this is activated, this is the three-dimensional image of the sinusoids, the portal triad, and this is the line in which the fibrosis proceeds. And if you see here, this yellow, this brown stained are the activated stellate cells. So it will progress from between the portal triads, and finally it produces the bridging fibrosis with this regenerative nodule that leads to cirrhosis. So why does a physician have to know about this cell biology? Now there are several studies that have shown targeting of the hepatic stellate cells can be therapeutic. Several studies have been conducted, is going on, and out of that, interestingly, if you see pioglitazone and obeticholic acid, which are in use now, they have action against the hepatic stellate cell by down regulating the adipogenic signals and having epigenetic effects. So this is expected to reduce the fibrosis or slow down the progression of fibrosis, and I think the future lies in stellate cell engineering, where nanomedicine techniques or other newer molecules could actually reverse the fibrosis or inhibit the activated stellate cells so that the fibrosis do not even happen. So this is a vision for the future. Of course, it will take time, but I think there will be a role of hepatic stellate cell engineering in NASH and other fibrogenic disorders like chronic pancreatitis. Thank you.
Thank you. Thank you. You can see that the most important factor in this is preventing the fibrosis formation by looking that the stellate cells do not get activated themselves. And as you rightly pointed out, people are working in this direction, how to see that they either act on the stellate cells and then see that they are not getting activated. Thank you. Thank you, Dr.
Thank you.
Rupjyoti,
Thank you,
for
sir.
this basic science, And we always been talking about diabetes, right from the beginning, and that's one of the important factors. Apart from lipotoxicity, there is what is called a glucotoxicity to the liver disease. Now, I would request Dr. Mithun to tell us what is exactly the relationship between the diabetes and the NAFLD, non-alcoholic fatty liver disease, because the management of diabetes is again a very important part in the management of non-alcoholic fatty liver disease. Over to you, Dr. Mithun.
Thank you. So the relationship between diabetes and non-alcoholic fatty liver disease is more of a love-hate relationship, I believe, because it's a bidirectional relationship. People who have non-alcoholic fatty liver disease can affect the worsening of diabetes because the basic pathogenesis of NAFLD is associated with insulin resistance, which includes glucose production and also production of lot of the small dense lipoproteins associated with diabetes. Similarly, diabetes, which leads to oxidative stress, increase in adipokines and also ER stress, that is endoplasmic stress, can also lead to progression of fibrosis as well as lead to development of hepatocellular carcinoma. As we are all aware that non-alcoholic fatty liver disease, the commonest cause of mortality is not in the liver disease, it's in the extra liver diseases, mostly cardiovascular. So a patient with NAFLD will have an increased risk of atherosclerosis, and this coupled with a diabetic patient who also has a risk of atherosclerosis, diabetic nephropathy and diabetic retinopathy in the future, possibly as the cause of liver cirrhosis will be more and more fatty liver, the treatment of liver cirrhosis will become difficult because we will have to treat diabetes, diabetic kidney disease, as well as cirrhosis of liver all in one go. This is a very nice curve which shows that as the patient is euglycemic in the initial part of his life and he doesn't have fatty liver, then the insulin sensitivity are also good. But as the patient starts to develop insulin resistance, and by the time there is beta cell dysfunction, that is, the person has become a non-alcoholic fatty liver at that stage and has become to gain weight, this is the time when possibly the diabetes sets in, and then there is more of progression of diabetes and also worsening of the liver functions. So diabetes may aggravate the course of non-alcoholic fatty liver disease, and also the liver disease, as we understand that in patients who have decompensated cirrhosis, some of the diabetic medications cannot be given, and this makes the management of diabetes also a little complex. So the prevalence of non-alcoholic fatty liver disease in patients with type 2 diabetes mellitus is around twofold higher than in general population. This is a graph which shows the prevalence of non-alcoholic fatty liver disease in patients with type 2 DM, and it has been found to be around 55%. If we see the zone of India with this, it is around 57%. It includes Southeast Asia. The highest is in Europe, around 68%. Also, the global prevalence, if we have to summarize, of NASH, not of just fatty liver, in patients with type 2 diabetes is around 37.3%. But this is possibly an underreported data because many of the time we don't make a diagnosis of steatohepatitis. Why I told it is a love-hate relationship is because some of the medications that are used in diabetes have also been tried in non-alcoholic fatty liver disease. And there are some very common links. For example, diet and exercise helps in non-alcoholic fatty liver regression as well as in improvement of insulin resistance and diabetes. There are some drugs like, as Dr. Roop has shown, pioglitazone, which has been proven in studies to improve the steatosis, though not fibrosis. Similarly, people have tried medications, and the most common amongst them is an Indian drug saroglitazar, which has also been approved now by the DCGI for treatment of NAFLD. It has also been used by the diabetologists for a long time to treat diabetic dyslipidemia since last around 8 to 10 years. So the relationship between diabetes and non-alcoholic fatty liver disease is a complex relationship. There are many common factors in the etiology and some common targets in the treatment protocol also.
Thank you. Thank you. The most important point which is mentioned is that the mortality part, the non-alcoholic fatty liver disease, the mortality is not because of a liver. Actually, it is because of a associated diabetes and the cardiovascular events which are done. That means that they are equally important, rather than you have to stress more on the management of diabetes and then obesity. And thank you, Dr. Mithun. And first, initially we thought how to assess the severity of liver disease. Biopsy is not possible for everyone, and then it's not acceptable also. And here we have a Dr. Anand Kulkarni who is going to let us know, are there any ways of assessing the severity of the fatty liver disease, the NASH, and particularly the fibrosis part about that, because that's very important one, without doing a biopsy? Over to you, Dr. Anand.
Thank you, sir. Actually, mainly for any NASH to be said that it is NASH or NASH cirrhosis or NASH fibrosis, biopsy remains the gold standard. There are some tests which can say that there is fibrosis. All these tests are good negative predictive value, but not pretty good positive predictive value. Importantly, in clinical lab tests, we have NAFLD fibrosis score, FIB4 test, AST-ALT ratio, AST to platelet ratio, fibrometer, fat liver index, and index of NASH. In imaging, you can do ultrasound. Ultrasound can also say that it is fatty liver, just plain fatty liver, when there is fat accumulation of more than 30%. Plain non-computed tomography, that is CT scan, can also say that there is a fat in the liver. MR imaging, MRI and MRI PDFF, which can say that there is MRI PDFF more than 8%, can also say that there is a accumulation of fat in the liver. Elastography can elastography is pretty good. It can also say that there is fibrosis in the liver. There are certain biomarkers which can help us say that there is the patient has NASH, such as hyaluronic acid, macroglobulin 2 binding protein, ELF score, and ProC3. Commonly used are AST to platelet ratio, that is AST normal patient's level divided by the upper limit of normal, whole divided by platelet count into 100. Less than 0.7 rules out fibrosis, 0.7 to 1 probably likely early fibrosis, more than 1 is proven fibrosis. More so, it is validated for patients with HCV cirrhosis, but it is also useful for NASH cirrhosis, NASH fibrosis. This is another score, NAFLD fibrosis score, which includes age, BMI, impaired fasting glucose, AST, ALT, platelet count, and albumin. You just need to enter the values. It will say whether the patient has fibrosis or not. The other score which is used is FIB4 score. FIB4 consists of age, AST, ALT, and platelet count. And NAFLD fibrosis score less than minus 1.45 says that there is it rules out fibrosis completely, but more than 0.67 may say that it predicts fibrosis. As I said previously, that these tests have more negative predictive value than positive predictive value. Similarly, for FIB4 test, the score less than 1.3 says that it rules out fibrosis, more than 2.67 says it might predict fibrosis. Most commonly, what we use in our practice is fibroscan, which is widely available now. We have an advanced machine which can say within 5 to 10 minutes that the patient non-invasively can say that whether the patient has fat accumulation, which is seen by controlled attenuation parameter, that is CAP score, and liver stiffness measurement, that is LSM, which is whether the patient has fibrosis or not. The LSM score less than 7 is normal, 7 to 10 is F1, F2 fibrosis, 10 to 12 or 20 to 13 is F3, and more than 12 is considered cirrhosis. Controlled attenuation parameter can also say how much fat accumulation is there. Score less up to 250 we say it is normal, 250 to 260 it is grade 1, 260 to 280 is grade 2, and more than 280 or sometimes 290, the cutoff varies from institute to institute, it is said to be grade 3 fatty liver. Certain other tests which is also done, like I said before, MR elastography, RP is also a pretty good test which is done by ultrasound. Radiologists can do it easily. It can also predict the presence of fibrosis in these patients. A score more than 2 may say that patient has cirrhosis.
Thank you. Just go back to the previous slide, previous one where you said that NFS, See, look at here. What do we require? Mainly we are interested in finding whether there is a fibrosis in the liver or not without doing a biopsy. And if you look at this slide here, what we require? AST and then ALT. I mean, AST and platelets, if you have, you can see, you can actually find out what is a APRI, right? And for NAFLD fibrosis score, you got the very simple parameters which are available in day-to-day our practices. And fifth score, you require only age, AST, ALT, and then platelet count. Having said that, there is a zone, where you cannot make out. You can exclude or include a fibrosis here, and that's where you have to take the help of the fibroscans. And you have partly dealt with the fibroscan, but we would like to hear from Dr. Rajesh. Nowadays, fibroscan is almost become like a stethoscope for a hepatologist, and almost every patient we do fibroscans as a baseline and also see the progress. Dr. Rajesh Gupta is a hepatologist. He is going to tell us, what is really the role of fibroscan in the liver disease. Over to you, Rajesh.
Thank you, sir. So already Dr. Anand has given a brief overview of where the test, and he has briefly mentioned about the fibroscan also. There are several techniques to assess hepatic steatosis along with the fibrosis. And I am sorry for the typo, it is fibrous, not fibro, it is fibroscan, not fibroscan. And it is basically a very simple non-invasive tool to assess the stiffness as well as the fat in the liver. And the machine is expensive, of course, but it is very easy to operate. And how does it work? It is basically we send a shear wave through a probe and it returns, and basically it creates vibration, and by the rate of velocity of the shear wave we measure the stiffness in the liver. And as Anand has already said, so we should take 7 to 10 valid measurements to get a good success of this procedure. So it is a very simple procedure. The machine is a little expensive, that is it, it is an initial investment. But the advantage of this this is basically how the procedure is performed. You identify the intercostal space where you put the probe with 9 to 11, and you generate a wave, and this wave it creates measure the stiffness, and by the velocity, measuring the velocity of this shear wave, you assess the value and you get a value, and which can give you an idea how the stiff the liver is. And this is a very simple cutoff values what we assess, and it is the advantage, as I said, is basically this data has been very well validated in large number of patients, and not only in NAFLD and other disease also we have. And similarly in a large population, Asian population, Western population, and this is the most validated data about, and practically there is very little need to do liver biopsy these days. If you have these standardized procedures can be performed in a good center with those who have good expertise of performing this procedure, and fortunately we have this good experience in our unit. So the cutoff, as I said, as Anand has also mentioned, anybody who is less than 7.5, we need not worry, it is simple for. So fibrosis is not there, it means fibrosis is not there, mind it. It does not tell you the fat, it tells you the fibro stiffness is less, so the fibrosis is minimal. But anything which is more than 10.5, practically it shows severe fibrosis. So you, if these two parameters you evaluate, you can very well clearly tell that the patient has significant fibrosis or minimal fibrosis or no fibrosis. In between, if somebody who is between 8.5 to 10.5, it means it is a significant fibrosis and you have to be careful. So this is the value of doing fibroscan and measuring the elastography and the stiffness of the liver. The problem, and another thing is, as Anand has also said, this you can measure the not only the fibrosis stiffness of the liver, you can assess the quantity of the fat in the liver by measuring control attenuation parameter. It exactly tell you how much fat is there in the liver. It gives a semi-quantitative measurement, and by these values you can quantify whether how much, whether it is a stage stage 3 fatty liver or grade 3 or grade 2 based on the values. So that is the importance of doing this simple procedure, and it gives you result in no time. It is a very short procedure and non-invasive procedure, but there are certain limitations. So it can be have some problems in certain conditions. They could be fallaciously high, sometimes it may be low, and but the advantage is obviously it's short procedure time, it can give immediate result, and it's a bedside procedures, and it requires minimal training, and it can be repeated multiple times during the course of the disease as well. You can see the progress of the disease, and you can test whether the fibrosis is coming down with the therapy or not. So that is an advantage where the liver biopsy is a problem, because this procedure liver biopsy cannot be performed repeatedly. Here this procedures can be repeatedly. So that is what the value of FibroScan in the management of fatty liver. I will stop here.
And of course, one of the limitations is that whenever there is a severe cholestasis is there or a congestion is there, then sometimes it give a very false value of a high values, then in which case you have to see that when after reduction of ALT, AST, one has to repeat the fibroscans. Well, so far we have talked about what is NAFLD, what is NAFL, what is MAFLD, what is the pathogenesis of non-alcoholic steatohepatitis. Of these, diabetes and then obesity are one of the important factors for the progression of the fat to the NASH and then fibrosis. We are not going to discuss much about the diabetes, but we are going to stress on the obesity part about it. We know that recently we had a International Obesity Day also. Here we have Dr. Rakesh. A patient comes and tells me that, really sir, tell me how much I lose will you ask me to lose weight to get my liver better? Dr. Rakesh is going to tell us what is the weight reduction and the benefit which you are going to get in the fatty liver. Over to you, Dr. Rakesh.
Yeah. So as it is multifactorial disease, so obesity being one of the major factors contributing to NAFLD or NASH, so there is something called as rule of 10, like any other rule what other diseases have. So it's like 5 to 10% weight loss is good enough. I'll tell you why it is called good enough. You don't say it is best. It's like we have to say the word good enough. That's because if you see this minimum weight loss, what happens around 10% in any obese person. So there are established evidences in literature that in your cholesterol or the lipid profile parameters, the HDL is a good cholesterol in layman terms. So the HDL will increase by 5 to 10%, 5 points if you have around 5 to 10% weight loss. And the triglycerides, which are the bad cholesterol, which are more pro cardiometabolic. So if you decrease your weight by 5 to 10%, they will be decreased by 40 milligrams per deciliter of triglycerides. And the hypertension also, the people who are hypertensive, they will be around 5 mm mercury of systolic and diastolic pressure decrease. And if you are a diabetic, probably if you lose weight by 10%, you will have around 0.5% decrease in your HbA1c levels, thereby having a better glycemic control. Insulin resistance, yes, again there is established evidence of weight loss leading to improvement in the HOMA-IR. Then obstructive sleep apnea, there are patients who had around 10% weight loss going off the CPAP who were already dependent till then. And of course, histologically, there is a proof in many studies showing with this weight loss, there is decrease in the pro-inflammatory cytokines, as it was told in the previous talks about the pathogenesis. So this is one good slide which I got it from Dr. P.N. Rao. So there is one study which is elegantly done about the percentage of weight loss and vis-a-vis the histological improvement in the NAFLD. So if you see this slide carefully, if you have a 3% weight loss, there is improvement in steatosis. If you have 5% or more than 5% weight loss, the ballooning or inflammation has improvement. And if you have more than 7% weight loss, there is improvement in the NASH. And if you have more than 10% weight loss, there is regression in the fibrosis. Mind you, this study is done not only with the imaging modalities, but also with the histopathological evidence. And these people who have had this weight loss of 5 to 10%, they had sustained weight loss at 1 year in this group, which they measured, which is around 10 to 30% depending on the weight loss what they had initially, which sustained the weight loss. So this is one thing which shows how important it is to have weight loss, and we don't have to go and then become very thin or target 20, 25%, 30% weight loss. So just a minimum of 10% weight loss if you can achieve, that will be a very good factor in the overall prognosis of your NAFLD. And just in a nutshell about the top 10 reasons of 10% drop in your weight loss, as I told you, decrease in the blood pressures, glycemic control, then improvement in your lipid profile, then other risk factors like cancers also can be foregone, because as we all know, this is again a precancerous state. Obesity is being a precancerous state. Then of course people who are overweight with other osteoarthritis and abnormalities, those inflammatory conditions also will decrease. Then as I told you, the OSA will improve, especially in people who are on CPAP dependent, might get off CPAP. Increase in the energy level, that will boost your physical and mental energy, and also your self-esteem, and also your people who are having this erectile dysfunction, there will be improvement in that also. So in a nutshell, weight loss of 10% is good enough for many of the things from head to toe, especially in people who are obese.
Rakesh, can you go back to the previous slide of the pyramid?
Yes.
Look at the right side corner.
Yeah. So
See
sustainability
that,
of
but
weight loss.
yeah, that's right. The amount, the people who could achieve the more than 10% weight loss are hardly less than 10%.
Right. Yeah.
So it means that how difficult, unless it should be a weight reduction should be a passion, for anybody.
Right.
And also you have clearly emphasized, what are the advantages of reducing the weight in terms of your lipids, in terms of your blood pressure, and also in terms
Diabetes.
of even more than 10% has been shown to reverse the fibrosis
Yes.
when they did the biopsy before and then after a period of about 1 year. But we have to, one is that for reduction of the weight, we need two things. One is a diet, and the other thing is a physical exercise. And at this point of time, let's not go into the diet too much of this. But here Dr. Mithun is there to tell us, what type of exercises, would you advising them for reduction of the weight? Over to you, Mithun.
So what type of exercise to do? I would use this line, just do it. So if you ask somebody how difficult is it to motivate somebody to exercise, you ask the NAFLD patients. And then they ask me, doctor, how many hours do I need to exercise a day? I tell them that it's minimum of around 45 minutes per day. But what I tell them, what is more important is just like as you tell a student that you have to get 80% marks in your matriculation examination. Similarly, I will tell you that you have to target this 10% weight loss. How you do it is mostly I leave it to the patients, but I tell them that there are some guidelines which tells us how and what exercise to be done. So studies have shown that initial studies were with aerobic exercise, where they emphasized that people should walk, do jogging, do cycling, any type of exercise where they are moving. But when you tell these patients, as Dr. Rakesh has just now told, by this time they will start complaining, doctor, I cannot walk because I already have osteoarthritis of the knee. The orthopedician is not able to solve my problem. So then came studies to see whether resistance exercise can also reduce fatty liver. And studies have shown in a biopsy proven study that people who do resistive exercises also can cause improvement in the non-alcoholic fatty liver disease. So what does the guideline says? The guideline from the easel says that there should be some structured program at lifestyle changes, and it's not only exercise, but it's a healthy diet, and then there can be reversal of fibrosis. In people who do not have NASH, that is biopsy proven, the guidelines are against giving them pharmacotherapy. So we need to exclude certain things from the diet and include certain type of exercise. As much as possible, it should be aerobic exercise, and the choice of training should be tailored based on the patient's preference so that he can maintain it long term, which is more important. It's basically a comprehensive lifestyle change rather than only exercise. Decrease the amount of fructose intake, that is the Coke based drinks. We do a calorie restrictions, target the 7 to 10% weight loss with a long term maintenance approach, which is important. In the diet, studies have shown that coffee consumption along with exercise can definitely help in improvement of fibrosis. It should be a literally low carbohydrate diet, and it can be high in protein, and it should be at least targeting 150 to 200 minutes of moderate intensity exercises, and resistant exercises should also be done to promote skeletal fitness and improve the other metabolic parameters. So basically any exercise you do, you have to do it. And this is the image when I was way back in Singapore, had this department runs. So the liver department had to run every week, and whoever does 5-kilometer runs every consecutively for 4 weeks, there was a motivation. They used to give them a shoe. So this type of things are important. Here we run only on the World NASH Day. We see a lot of people having a run on the World NASH Day and then forget it for the rest of the life. So, and many people who say, I am very busy, I don't have time, I tell them that if you have time to attend to your Facebook updates, you definitely have time for exercise. Because people who think that they have no time to exercise, they will soon have significant time to spend for their illness. So exercise is the key. Do it. Just lose that 7 to 10% weight to reverse your fatty liver.
Thank you. Thank you, Dr. Mithun. Sometime before, we have I have seen in the social circles in the WhatsApp media that coffee is good, and then you take more amount of coffee, that helps many things, including surprisingly the fatty liver also. Here we have Dr. Anand, who is going to tell us about, how does, what is the relationship between taking a morning coffee and the fatty liver. Over to you, Rakesh.
So coffee is definitely a very good antioxidant. Each cup of coffee contains around 100 to 140 milligrams of caffeine. This caffeine is responsible for the reduction of fibrosis, as Dr. Mithun already told. There was a study which said that compared to non-daily drinkers, subjects who drank more than 1 or 2 plus cups at 38% and 66% reduction in the mortality from non-viral hepatitis related cirrhosis. Why? Because coffee contains polyphenols and melatonin, which can decrease the fatty acid beta oxidation, mitigating oxidative stress and curtailing liver inflammation. It has cafestol, kahvol, which can induce the phase 2 detoxifying enzymes, including sulfotransferase, UDP glucuronide transferase, glutathione transferase, and peroxidase, and can contribute to the antioxidant property of coffees. Polyphenols and dieterines, which can downregulate the pro-inflammatory and fibrogenic cytokines such as TGF-beta and CTGF, and reduce the stellate cell activation. So coffee is definitely very beneficial for all patients, for any cirrhosis patients, be it NASH or non-NASH. Any cirrhosis, alcoholic liver disease can also be benefited from coffee drinking. A cup of coffee will contain around 100 to 140 milligrams. 2 to 3 cups per day is the recommended coffee intake, which can reduce the fibrosis. It also has anti-inflammatory properties as well. So another study which was published in Hepatology, which said that the association of coffee and caffeine consumption with fatty liver disease. There is significant reduction in the fibrosis stage in patients who consume coffee daily. So coffee has anti-inflammatory and antioxidant and anti-fibrotic properties.
Thank you. Coffee is good, but not the way we take the coffee, because we take with it too much of milk, too much of cream, and too much of sugar. That's not the way. That coffee is not going to help. The coffee which is going to help is which has got the very low amount of these two kind of a thing. That basically black coffee, as a Indians, many people don't like that. So don't be under the impression that the way we take the coffee with too much of milk and then too much of sugar, that is going to be counterproductive. You have to remember that it is the black coffee that is one which is going to help us. And we talked about a lot about the diet, the exercise, and the coffee. Now let's look at, do we have any drugs to, at any stage of the fatty liver disease, either a NASH or a fibrosis, do you have any drugs to be taken? How long are we have take these drugs in a non-alcoholic fatty liver disease? Here we have Dr. Rajesh Gupta, who is going to tell us about the drug pharmacological issue management of a fatty liver disease. Over to you, Rajesh.
Thank you, sir. Once again, now let's comes to the management part. So the first two important aspects have already been covered by Mithun and Anand. So I will re-emphasize that lifestyle modification, exercise, diet, they are the cornerstone of management of fatty liver. But those patients who had significant fibrosis and inflammation, what we call NASH, we need pharmacotherapy for them. Everybody does not require pharmacotherapy, but there is a subgroup of patients who need treatment, drug treatment, of course they need. So, this we have been trying to understand this pathogenesis of NAFLD for last many decades, and now we have come to understand that there are several steps which are involved, from simple benign fat to advanced cirrhosis, and there are intervention which can be done, and there has been some data both in animal and human studies where the drugs have made some difference. So, there we can intervene at the level where the fat is deposited in the level de novo deposition of fat, there we can intervene. If you have fat generation in the liver, so you have inflammatory state, you have fibrosis state. So, there are different stages, and there are different molecules which have been identified which can work in different stages. I am not going to go in details of all these things because this is not the meant to be discussing at this stage. So, what I am my main question is, I am supposed to answer what are the drugs which are available in India and which are beneficial for the patient. So, first come to the drugs which are available in India and which are been approved for treatment of NASH. This is the most important drug is vitamin E, pioglitazone. So, these are available in India and these have been good data to support. Second is seroglitazar. It has also been now approved in India, but not in other international societies, they have not approved it yet, but it is also one of the drugs which has been used, and we have also been using in our unit, but that we need more data to support the use of this drug. The second class of drugs which are available, but they are not specifically approved for management of NAFLD or NASH. So, as already been discussed by Dr. Mithun, that there are anti-diabetic drugs which have been found to be beneficial, because if we manage the diabetes better, we get good results in management of fatty liver also. So, it is basically a symbiotic relationship if you manage diabetes well, and these are the drugs which are available. And of course, there are certain things like vitamin D and probiotics, I think microbiota. So, this role has also been emphasized, and we are going to have exciting data in near future on these drugs. Secondly, a third group is the drugs which have been used in clinical settings and clinical trials, but they have not been found to be too much beneficial, and there is some controversy and still the data is not very clear. So, one of the drug which is currently available in India is obeticholic acid. Rest of the drugs which has been tried in studies excuse me, in international trials, but obeticholic acid has been tried, that is good data, but still the data is not convincing enough to recommend on a routine basis. So, now coming to just one important landmark study which was published in NEJM long back, and this study has clearly shown that pioglitazone vitamin E is superior to placebo in management of NASH. So, that is the reason this is one drug which has been accepted by international society for management of NASH. There is some data from India also, and there is some, this is international data which showed saroglitazar. So, it is a dual PPAR agonist which has been also been tried, but it is still the data is not very convincing, but this is one drug which has been beneficial both in diabetics as well as NASH. This is the advantage, whereas vitamin E has been primarily used in a group which were non-diabetic. So, these are another drugs which, as I said, they are available, some of the drugs are available in India, but they have not been approved primarily because of the there is lack of convincing data on the in the role of NASH, and some this liraglutide and semaglutide, they are available in India, but semaglutide is available in India, but there are some data is there, but it still the data is emerging, and in future probably we will have more data to approve will give us more confident in using these drugs for management of NASH. Elafibranor and other drugs, they have been tried in international trial, but they have not shown much benefit. So there are a lot of drugs which have been shown negative results. So the trials have been halted midway, and some of those trials have been abandoned. So I am not going to discuss all these drugs. And coming to the last slide, so this is what the various societies they have recommended. As you see in this is a busy slide, so several drugs are listed over here, but if you see only the ASLD recommends only the vitamin E because there is a randomized control trial. Rest of the societies, they just say that data is not convincing, it is just on the basis of clinical protocols or on the research protocol you can recommend drug. But I would say in India we have vitamin E, we have pioglitazone, and we have saroglitazar, these drugs, and saroglitazar especially in diabetics, and we have some data from India also which has shown some decrease in necroinflammation also, and some improvement in biochemistry also. So obeticholic acid is another exciting drug which has been recently, there is a lot of talk about this drug, but the data is still emerging. And the second problem with this drug in India, this drug is not approved for NASH, it is primarily for PBC, and the dose it is required is very high dose, the drug become very expensive and it's a lot of side effects. So this drug is still, the jury is still out on this issue, so I will not recommend obeticholic acid at this day for Indian patients. Thank you very much. I will stop here.
Thank you very much. We have to clarify here what Dr. Rajesh has said, that many of these anti-diabetic drugs have alone cannot be given in the people with the NASH who do not have diabetes. But we have to remember that many of the people will have a NASH and also the diabetes. In these people, metformin forms the bone, and the other two drugs which are being found to be helpful are the GLP-1 analogues and SGLT inhibitors, and these are the drugs which are going to help the NASH part also in addition to the diabetic part. So all these things, diet, the drugs, we still is not possible that some of the people who are very morbidly obese or in these people it's not possible with the drugs alone. There we have to find out some other ways. Here we have Dr. Rakesh, who has been working a lot on these obese people, as to he will tell us how to tackle this in terms of the bariatric management or a metabolic management. Over to you, Dr. Rakesh.
Yeah. So as we discussed earlier, 10% minimum weight loss. So you do diet, you take care of physical activity as has been told, but with this also obviously you will be reaching 2 to 3%. It's not that easy in this busy lifestyle and busy schedule with all the stress prevailing. So to have a 10% weight loss as easy as said. So without surgery, do you have anything in between? Diet, physical activity, and then surgery in between. So there is something called as bariatric endoscopy, which is getting evolved in the last couple of years, and then that's going to be there for the next 1-2 decades. So if you see in gross about what we do in this bariatric or metabolic endoscopic therapies, is you address either the gastric part, that is the stomach you play upon, or in the duodenum, very small bowel. So these are all different things which are there in work in current clinical practice, the intragastric balloons, then the endoscopic sleeve gastroplasty, that is suturing of the stomach. Then you have flow control, that is the aspire assist, and also the balloons which will stop at the pylorus for the food to traverse down. Then you have the small bowel therapy, that is duodenal jejunal bypass liners, intestinal bypass, and mucosal resurfacing, which is again mainly concentrating on the diabetes, which Dr. Reddy is going to speak on. So predominantly what one has to understand is, if you deal with the stomach, that means that you are achieving weight loss with the metabolic effects dependent on the weight loss. But if you are dealing primarily with the small bowel, you are dealing with the metabolic effects independent of weight loss, but there will be some weight loss which will be partially there. I'll just show you what is exactly is that. So if you see this, on the left side you have the gastric endoscopic bariatric metabolic therapies, which includes an intragastric balloon, then a transpyloric shuttle, as I told you earlier. Then this is a device called full sensory esophageal stent, which you put in the GE junction, which causes early satiety. Then you have the endoscopic sleeve gastroplasty, also aspiration therapy. What happens in this set of gastric weight loss dependent pathways is you create early satiety, then you alter the gastric accommodation, induce artificial gastroparesis, and thereby the insulin resistance improves because of weight loss. Whereas when you come to the small bowel metabolic or bariatric metabolic therapies, so you have the duodenojejunal bypass liners, which exclude the proximal small intestine, that is the duodenum, D1, D2. Then you have the ablative techniques, which include duodenal mucosal resurfacing, and also the incisionless magnetic anastomosis. So what happens in this is you will have obviously a little amount of early satiety, and you will regenerate the gut mucosal barrier by altering the gut microbiome, which, as earlier we told, that gut microbiome leaky syndrome is one which leads to pro-inflammatory cytokine increase leading to NAFLD. So that is one thing which is advantageous, and also insulin resistance. So if you see these gastric pathways and small intestinal pathways, as on the first column, the intragastric balloon, transpyloric shuttle, full sense device, gastric remodeling, aspiration therapy, there is a phenomenal improvement in a decrease in the body weight around 10 to 15%. And also the studies have shown that the ghrelin activity decreases, because ghrelin is the hormone which will increase your appetite. Whereas in the small intestinal pathways, if you look upon, then the duodenojejunal bypass liners, the duodenal mucosal resurfacing by ablation techniques, or the anastomotic creation by magnets, there you have significant improvement in insulin sensitivity, because you are playing on the duodenal metabolic, which is the metabolic center for control. And then also there will be increase in insulin secretion, because there is something called as ileal brake, which a bariatric surgery surgeons will do with the ileal bypass, which is alike, and it can be done endoscopically, which is a minimally invasive procedure. And of course there will be also improvement in the energy expenditure. So these pathways, which if you can address endoscopically, definitely that minimum weight loss of good enough weight loss of 10% can be achieved with these modalities, which is evolving, and many of them have evolved. And there is a telltale evidence with good randomized control trials which have shown that these are safe, efficacious, and also have a significant positive effect on the obese people to have weight loss, and thereby on the metabolic syndrome also.
And see, many people, we have a great difficulty in convincing them for these procedures.
Yeah.
Whenever we tell them, they say that, no, sir, I will come back again, I will try my own methods with the diet and then
Right.
exercise.
Yeah.
How do you really talk to them?
So what we have to tell them is, initially they will be probably coming there after touching 3-4 people, and then all the doctors will say you should have weight loss. So you have to motivate them, because most of them are busy in their own schedule. They don't even find time to do exercise. And food again is, it's very tempting. Unless until you have a real willpower, you cannot really have a control on the food. So if you can tell them, as I told you, this good enough weight loss of 10% can be achieved in a minimally invasive daycare procedures without any surgery or any scar. This is like scarless. Then probably they get motivated with that, and then that is kind of a bridge to therapy. And of course, if they are morbidly obese, then obviously surgery is the best option.
Okay. Among these bariatric surgery and then endoscopic bariatric interventions, which has come first?
Obviously, bariatric surgery.
Oh, right. So you have a competitor then.
Yeah, I'm sorry. We work in conjunction, and the next
Okay.
speaker is my very dear colleague who will talk on surgery.
And can we have your competitor here, Dr. Abhishek? You've been working a lot, and then
No, he's not my competitor. He's my.
All right, I'm going to put you both of you stay there. Rakesh, don't go there.
Okay.
Just stay there. Yes, Abhishek, you just take over.
So,
And
as
then-
rightly mentioned by Dr. Rakesh, we are not competitors. We are just brother from another mother.
Okay.
So just knowing the problem will not solve it. We have to be really proactive to understand the gravity of situation and to decide which modality you are going to choose, not only to prevent but also to treat non-alcoholic fatty liver disease. My colleagues have already enlightened you about the gravity of situation. I shall be talking about the solution part. Now, a very valid point raised during the course of discussion is losing weight is not difficult. A lot of people say that I've done it several times, but the problem is maintaining that weight loss. So we should be looking at something which gives a long-term weight loss and the all effects of losing weight. So being a bariatric surgeon, I shall be talking about the importance of bariatric surgery here. So first, let me clear out few myths and let's bust those myths which are usually concerned when we talk about the bariatric surgery. So the first one is, it's not a cosmetic procedure. Don't confuse and confuse it with a liposuction. No big scar. A lot of people are scared. When we talk about surgery, they think that there's going to be a big scar, I would be bedridden for a long time. Believe me, it is done by keyhole surgery with just 2 or 3 holes of 2 centimeter, and then it's a procedure which is done and then you don't come to know about it. Hospitalization, you will be discharged within 48 hours of the procedure. There's no need of long bed rest. You can walk within 4 to 6 hours after procedure. There is no need of putting Ryle's tube or Foley's tube or anything, and you can resume your daily activities as early as possible. The diet, a lot of people think that once you have bariatric surgery, you have to be on liquid diet, you have to eat boiled food and all those things. This is all myth. The diet goes on a phased manner, starting with a liquid diet, slowly going towards a pure diet, and finally whatever is the family eating, the family basket. The next question which a lot of people ask is, how much weight I'm going to lose? So usually we expect 60 to 80% of excess weight loss. So to give an example, if somebody's current weight is around 120 kg and the ideal body weight according to the height and different WHO graphs is 80 kg, so he has an excess weight of around 40 kg. So we expect them to lose 80% of 40 kg, which is around 32 kg. So the person is expected to lose 32 kg over a period of 1 year, and that would be a sustained weight loss. Now, obese and diabetic with non-alcoholic fatty liver disease, my colleagues have already explained about what mechanism does it play, how when you lose weight, how does it affect, and this weight loss can reduce, not only reduce but resolve NASH inflammation including fibrosis, and improves the longevity. About 92% of people with non-alcoholic fatty liver disease saw an improvement in statuses and 70% a complete resolution after bariatric surgery. The Asia Pacific Working Group on non-alcoholic fatty liver disease have already recommended bariatric surgery as a treatment option for those with class 2 obesity, which is BMI more than 32.5 for Asians and 35 for Caucasians. Now let's talk about the different surgeries which are available. The most common worldwide procedure which is being done now is a sleeve gastrectomy, in which we resect about 70% of the stomach, and then there is a long slender gastric tube. We know about the ghrelin hormone, the hunger hormone, which goes off, and there is a change in the anatomy, and there is change in the gut hormone which happens after sleeve gastrectomy. The next procedure, which is gold standard procedure, which is called laparoscopic Roux-en-Y gastric bypass, in which we make a small gastric pouch, and then once this gastric pouch is created, we anastomose small intestine here, and it looks very bizarre, but believe me, after this procedure is done, people lose weight and they come back to us thanking us and saying that it has changed their life. The next procedure, which is getting a lot of popularity nowadays, it's called laparoscopic mini gastric bypass or one anastomosis gastric bypass, in which we again create a small gastric pouch, but in this we do a loop gastrojejunostomy, so that the whole bile comes from the stomach and biliary content which comes, and then they mix up with the food and they pass down. So again, this procedure is gaining a lot of popularity. That we cannot go into the detail of each and every procedure in this short duration of time. And if you're really interested to know more about it, we can log into our AIG website, into the Center of Obesity and Metabolic Therapy, and you can get more information about this procedure.
Thank you, Dr. Abhishek. Just tell me, I will withdraw the word competitor. I will say that both of you are complementary. When do you think that, that endoscopic surgery requires to be done is better than not better than this one, not fit for?
So it's not me, it's an international data which suggests that if somebody has a BMI more than 40 or has comorbidities like diabetes, severe obstructive sleep apnea or NAFLD, then they will usually, we do not recommend them to go for endoscopic procedure. And I'm sure my colleague Dr. Rakesh will agree with my recommendation. So anybody who has BMI more than 40 and has comorbidities should opt for bariatric procedure because it is now very safe.
Thank you very much. So we have done away with how to manage the obesity, but the most important other part is the management of the diabetes. And so far people have been using as a now, the lifelong anti-diabetic drugs. Dr. Reddy is going to tell us now, is there any progress in this particular field? Whether can we do away with the drugs, and is there any procedure endoscopically which can be managed for the diabetes? Over to you, Dr. Reddy.
Thank you, Dr. Rao. I think this is an exciting area. The common link between NASH and type 2 diabetes is insulin resistance. For a very long time, we used to think that insulin resistance was actually coming from excess insulin being produced and all the receptor cells having resistance for this. In recent years, there has been an increasing amount of knowledge suggesting that this is partly related to factors which are originating from the duodenum. And let me explain this to you. If you can get to my slides, normally what we would think is that the glucose metabolism is controlled by pancreas, right? But this is wrong. Our thinking has changed now because we know that when the food passes through the intestine, the first contact area after the stomach is duodenum. So obviously body or nature has mechanisms where the initial control would be in the duodenum and not in the pancreas. So the brain, the metabolic control is actually in the second, third and fourth part of the duodenum. And let me explain this to you in a more simplified way. So when we take food, the food passes through the stomach, gets digested, goes to the duodenum, and there as it goes to the duodenum, it stimulates cells which secrete incretins and so-called anti-incretins. Now this secretion of incretins and anti-incretins results in so-called euglycemia. The term anti-incretins is being replaced by insulin resistant factor or a diabetic intestinal peptide. The reason why it's being replaced is there is increasing belief that there is a specific peptide being secreted from the duodenum which actually is producing the insulin resistance. So it's called the insulin resistance factor, and a lot of work, again can't go into the details because of the time, a lot of work, fundamental work is going on in this area. So this balance of incretins and insulin resistant factor results in euglycemia. But what happens now? Now you see we are taking refined foods which contains low fiber, high calorie and so on. So increasingly because of this, the anti-incretins or diabetic intestinal peptide is being increasingly secreted. And what this does, increasing of this results in increased blood sugar, TGL or NASH, all because of insulin resistance. So there is some factor in the duodenum which is being secreted which is causing insulin resistance, and as I said that discovery is going to come soon because the duodenum actually is a factory of production of lot of neuroendocrine hormones resulting in a variety of metabolic processes. So this is the controller center for metabolic control. So this balance between incretins and anti-incretins or balance between incretins and the duodenal intestinal peptide results in disbalance, results in so-called insulin resistance. So how does this affect us? This is a very elegant study which has been recently published in Annals of Surgery. These were patients going for metabolic surgery, severely obese, type 2 diabetes, in whom Roux-en-Y gastric bypass like Abhishek has described was being done. These patients started with hyperglycemia And when a Roux-en-Y gastric bypass was done, food was actually passing, orally given, was passing, bypassing the duodenum and going down to the jejunum. And in these patients, immediately after this procedure was done, within 4 days time, they became normoglycemic even without any medication, indicating that if you can bypass the duodenum, you can achieve a state of normoglycemia. But these investigators then put a gastrostomy tube post-operatively and started feeding not only orally but also through the gastrostomy tube. So when they started feeding through the gastrostomy tube, small amount of food was given. This resulted in hyperglycemia. Small amount of food stimulating the duodenum, stimulating an insulin resistance factor there, resulted in hyperglycemia. But when the tube was removed and normal food was given, they came back to normal glycemia. So these elegant experiments demonstrated for the first time very clearly that there is some factor in the duodenum which is controlling insulin resistance, and we can probably manipulate it endoscopically. So duodenal nutrient passage strongly influences insulin sensitivity independent of weight change. Actually, we have a precedent for this. One of the devices that came for bariatric use to reduce weight was an endo barrier, which could be fixed into the duodenum. To bypass the duodenum, food went into the jejunum. This not only resulted in a decreased amount of weight loss, but also control of diabetes. But unfortunately, this device is no longer in use now because of certain complications. This is a temporary method. Can we do something more solid? And this is the technique of duodenal mucosal resurfacing procedure, which has now come into force. And this was a concept again that if we destroy the duodenal mucosa, the new mucosa which regenerates doesn't contain the same neuroendocrine cells, and therefore the insulin resistance factor is not secreted and diabetes is corrected. And in fact, this is a very simple endoscopic technique where upper GI endoscopy is done, and the part of the duodenum below the papilla, second, third and fourth part of the duodenum are then mapped out, and using hot water at 80 degrees, you can actually burn the mucosa after separating the submucosa from the mucosa. And once you do this, you can produce a complete mucosal burn. And these are actually pictures to show what happens when you lift up the duodenal mucosa. You can see the bluish mucosa there, and then you can see a burn. And after 3 months, macroscopically, the duodenal mucosa comes back to normal. But microscopically, there is a difference. The neuroendocrine cells that are there don't come back to normal, and that's why the insulin resistance factor is not secreted. There is now a large amount of data. I don't want to go into individual data, but there is a large amount of data now available which is showing that after this duodenal resurfacing, mucosal resurfacing, there is a reduced glycemia. A1C improves almost by 1.5, which is very significant. Fasting plasma glucose comes down, and NASH improves significantly. In fact, there is a large study going on in Erasmus in Brussels where they are actually treating NASH with this technique. Paired biopsies are being done before and after the procedure, and showing that there is a decrease not only the inflammation but also fibrosis. So all the enzymes come down, insulin sensitization occurs, and all the metabolic parameters improve, including the antioxidant capacity. All this suggests that the duodenum is the center for metabolic control in the body, and altering the duodenal mucosa can actually change it. So I think we finally know about the metabolic role of duodenum in insulin resistance, the physiological role. We know that due to our diet changes over the last hundreds and thousands of years, there is an evidence to show that hyperplastic of the mucosa occurs in the duodenum, and we know that using endoscopy we can actually change this either by bypassing this area by variety of techniques, and DMR is one of the most important techniques that's coming up in recent years. So I think the answer to this metabolic syndrome that we have seems to be endoscopy in near future. Thank you.
Thank you, Dr. Reddy. Would you please join me here? See, in these days, nothing goes without talking about COVID.
Yeah.
Right? We have to give some message to our viewers, who have been sitting through for the last 1.5 hours. The COVID, diabetes, and obesity.
Yeah.
So
I think this is an important area. We have actually found, and this is evidence in literature also, that obesity is one of the bad prognostic signs for COVID. We know that people who are very obese, a BMI of more than 35, increased chances of mild disease progressing to severity, and death rates, mortality increase. we also know that the COVID virus can actually has receptors both in the SNR cell of the pancreas and the islet cells. So, COVID virus can actually attach itself to the virus to the islet cells, and what we have seen is that not only is a new onset diabetes coming up in some of these patients, but also there is evidence that patients who are diabetic already, with the onset of COVID, the diabetes worsens, not just because of steroids, but also by COVID itself. So, there is, I think, a strong interlink between obesity, diabetes and COVID, and this is a triangular interlink which worsens when COVID occurs.
Thank you very much for this one. I think we have to give a final message is that, don't be worried about the fatty liver. Just look at the liver functional test. If ALT and then AST, SGOT, SGPT are elevated, for which there is no other cause, that means the diet, the drugs and the viruses, then you have to try to reduce that mainly by the diet and then exercise, and also taking care of the diabetes. And remember, tomorrow, that is the 10th of June, is the International NASH Day, and on this day we rededicate ourselves to how to prevent the going on to the NASH and then fibrosis and cirrhosis by taking care of the obesity and the diabetes. And thank you very much, and thank you all my colleagues who have participated for the last 1.5 hours in this one. Thank you, Dr. Reddy.
Thank you.
Thank you.